right, so I'm Casey Mullen, and I'm going to be doing the cervical breakout. I'm having to do it on a dried spine, so if I need to do this again when I get a real subject, then I will totally be found doing that. But anyways, so with these cervical breakouts, we're basically going to be looking if it's a stability versus mobility. So what I mean by that is, can they perform it? So if they're unable to perform it actively and also unable to perform it, when I add that passive movement, we're looking at it probably going to be more of a mobility issue. On the other hand, if they're unable to perform the movement actively, but I can get them into more of that position passively, then we're probably looking at more of like a stability motor control issue. So with that being said, we're going to start with the cervical flexion, and we need to start with the top tier. So with this, we're going to have the patient nice and neutral, feet together, and we're going to have them instruct them to bring their chin to their chest. So I'm able to do it, and I'm also, I don't have any pain, so I'd be FN, but for the sake of this video, we're going to say that they weren't able to complete the movement. So if they're unable to touch their chin to their chest, we're wanting to see how far away they are from being able to do that. So we can use our fingers. So for the sake of this video, we can say that they were about 3 fingers away from being able to complete it. Next, we're going to lay the patient supine, and then we're going to have them just actively do the same thing. So supine, keep in mind that they're working against gravity now to do that flexion movement. So yeah, just to keep that in mind. So they're supine, they're nice and relaxed. Now we're going to instruct them to please actively flex their chin to their chest again. And again, for the sake of the video, we'll say that they're unable to complete it, and we want to see how many fingers they are away from touching their chin to their chest again. So now that we know they can't do it actively, now we're going to go and do it passively. So with this, I am going to just rest my hands behind their head, and just passively flex them up. So can't really show you this, but I just flex them up and just see if we're able to complete that motion. So for the sake of this video, again, sorry that's kind of repetitive, but we're going to go ahead and say that they are having a mobility issue. So they're unable to do it actively, and we're also not able to get that full flexion passively. So there is a special test for this. It's the OA test. So what this is doing is it's basically letting us know where this mobility issue is at. Upper cervical, lower cervical is at the occiput on the atlas. So with this one, since it's the flexion, we'll start with rotation. So this is all passive. What I'm going to do is I'm going to get behind the patient. The OAs account for about 20% of that flexion. So we're going to see if it's OA or if it's the cervical region. So I would just have them relax. I would grab their head, and I am just going to rotate them to each side, and then I'm going to ask them to tuck their chin into their chest. And I want to see them get to that 20 degrees. All right. And then we'll do the other side. And I'll just ask them again to tuck their chin into their chest and get that 20 degrees. So with this, if they're able to clear it, then we're probably looking at some sort of lower cervical or cervical region. If they aren't able to clear it, then we're looking at those OA joints. Alrighty, so next we're going to go into cervical extension. So with this one, first we need to start at the top tier. So keep in mind with the extension, we have a pretend line going from the chin to the forehead, and we're wanting to see if they can get to that 80 degrees or 10 degrees from parallel. So we'll have them face forward, and we'll just ask them to extend their neck back. And I'm pretty sure I get there. I don't know if you saw me in the camera, but so with that one, if I wasn't able to complete it, we're gonna jump right into the test. So there's no special test for this one. We're gonna lay the patient supine, and the biggest thing with this is that we want to make sure that their shoulders are off the table, but not so much to where they're tense and their postural muscles are super tight and stressing. We want them as relaxed as possible. But we do want to be able to get that full extension passively when we continue. So we just want to make sure their shoulders are off the table. Nice and neutral, and we want to keep their trunk on the table as well. So now I'm going to passively take their head, and I'm going to passively bring them into extension, which I can't do on this very well, but I would grab them and just bring them into that extension. And with this, we're just seeing, mobility versus stability. So since hypothetically, if they weren't able to do it actively during the top tier, and then I also can't get that any more of that extension as we do this portion passively, then we're looking at a mobility issue. And if I am able to get more of that extension doing this movement passively, then we're looking at more of a stability motor control issue. Alrighty, sorry I am talking quick. The last one we're going to do is cervical rotation. So we're going to start with the top tier. So at this one, we would get behind the patient, find that AC joint, that SC joint, and get right in the mid-clavicle region. And we're wanting to see if the patient's nose and chin can clear that line on each side. So we're looking at that straight plane 80-degree rotation. So we would find right here, and we just ask the patient to look left and then look right. So I do have a little trouble with this one. So I would be dysfunctional, no pain. I'm gonna go ahead and keep that for the sake of this video. So now we're gonna take the patient, we're gonna lay them on their back again. We don't want their shoulders hanging off for this one. And then we're gonna have them actively do the exact same thing, just looking at, again, that mid-clavicular region. We're gonna see if their nose and chin can clear. So we'd have them actively turn to the left and then watch them do the same thing to the right. So if they're unable to really complete that, we're starting to think mobility maybe. We're gonna go ahead and do it passively. So with this, I'm just gonna grab their head and I'm going to passively rotate them. Okay? And one of the biggest things with this is we wanna make sure that their spine is nice and neutral, that their trunk is staying on the table, and just staying in that plane. We don't want them to, be tapered off. So after that, there is a special test for this. So if they weren't able to complete it actively and we're not able to get that extra rotation passively, we're thinking some sort of mobility issue, and now we just need to see where. So there is a special test that's testing for C1, C2. So out of the 80 degrees of that straight plane rotation, about 40% 40 degrees or half of the percentage comes from C1, C2. So now we're gonna go ahead and do this test that determines or differentiates if it's cervical issue going on or if it's C1, C2. So with this one, since it's a rotation, we are starting with flexion. So we are going to passively take the patient and we are going to passively flex them up, which their whole spine would not come up like that, but I'm working with what I have. But we're going to just flex them up, and the purpose of that is to lock out that lower cervical spine. So now that they're passively flexed up and they're locked out, we're going to ask them to rotate to the left and then rotate to the right. So they'll rotate to the left and then they'll rotate to the right. And basically we're seeing here, if they're able to clear that line again or get that 40 degrees of rotation, we're thinking that the C1, C2 is fine. Since the cervical is locked out down here and they're still able to get that 40 degrees, we're thinking, okay, probably going to be a cervical issue. And vice versa. So if they weren't able to get that 40 degrees and the cervical spine's locked out, we're thinking, okay, maybe it is a C1, C2 issue going on. Yeah, so that's the cervical breakout. I am going to go ahead and just do the rest of the top tier, just in case. So now that we've done all the top tier cervical portions, just to recap, the upper extremity pattern 1, we're looking at that extension and medial rotation movement, and we just instruct the patient to take their arm, and we want them to touch their opposite inferior angle of the scapula. So we just have them forward, neutral, feet together. And we'll just have them bring it back and touch that opposite side of the scapula. We're looking for nice smooth movements. We're looking at the winging of the scapula. Keep in mind a little bit of winging is normal, but it's just really the clinical decision on if it's dysfunctional or not. We're also looking for any radial deviation. Don't want them cheating or accidentally altering the test. And I'm just looking for any kind of dumping or compensations. So the next thing is the upper extremity pattern 2. So with this one, we're looking at that flexion of the shoulder. So we would instruct the patient to bring their elbow up to their ear. I'll step back. Bring their elbow up to their ear and up behind their head, and they wouldn't turn like that. And we want to instruct them to touch the spine of the scapula on the opposite side. And we're looking to see, that 170 degrees of abduction and flexion in that shoulder. And there's a few different things for compensation. Are they hiking that shoulder? Are they, dropping their neck, dipping down, anything like that? The next one is we're going to do multi-segmental flexion. So with this one, we're essentially just watching the patient do a toe touch. So we'd have the patient take their fingertips, touch their toes, but keep their eyes on their toes as they do this movement. that's just to standardize the cervical spine, so there's no cheating here. So fingers to toes, then touch. First and foremost, can they touch their toes? Because if they can't, we're looking at some sort of dysfunction going on. And we also want to look at any kind of posterior weight bearing. We want to see that, and then also we're looking at sacral involvement. Is there 70 degrees of that sacral involvement or more? And then we're just looking for the overall curvature of the spine. Is the full spine contributing? Is it flat in certain places? Are they overcompensating and flexing at the end, etc.? Next, we're going to do multi-segmental extension. So with this one, and this is with their arms up, we just have the patient bring their arms up to their side, and we're going to ask them to extend back. So there's a few things with this. First and foremost, are they able to complete this with their shoulders at that, and maintain their shoulders at that 170 degrees of flexion? Also, are their ISs being able to clear their feet in the front? And are the spines of their scapula able to clear their heels in the back? We also want to look for any, pelvic dumping and a nice uniform spinal curve there too. Next, we're going to do, we're going to do the multi-segmental rotation. So with this one, we're looking for 50 degrees of that pelvic involvement, and then about 50 degrees of that shoulder or full spine and thoracic involvement. We'll have the patient just face forward. We'll just have some turn to the left and then to turn to the right. Keep in mind, we don't want to see them dumping their pelvis or flaring their toes out or anything like that. So another way to look for this is the doctor can stand behind the patient and they want to be able to see that opposite shoulder when they're turning. The next one is going to be, where are we at? We just did multi-segmental rotation. All right, so now we're going to do the single leg stance. So we're going to perform this first with your eyes open and then with your eyes closed. Keep in mind, even if they're considered dysfunctional with their eyes closed, we still want to go ahead and perform it with eyes, if they're considered dysfunctional with their eyes open, still want to do it with their eyes closed to see that pain or anything. So we just want to ask the patient to get on, I don't know if you see me, 1 foot, no shoes. And we just want them to barely bring that toe up just enough to clear the ground. And then we're going to ask them to hold it for 10 seconds. Look for any excessive swaying, just really see if they can hold it. Then we'll move to the opposite side. So I think I'm pretty functional there. I did tear my unhappy triad, so this one might be a little tougher. But again, 10 seconds. After that, we're going to move into the eyes closed portion. With this one, there is about 50% more acceptable swaying just because their eyes are closed. Before they do close their eyes, go ahead and allow them to get into their single leg stance and then have them close their eyes. And I'm pretty dysfunctional on this one. No pain, but definitely dysfunctional. Yep. On this one, do the opposite side, wait 10 seconds. If you see their head drop, we're automatically considering it dysfunctional just because there is so many different compensations that they could be doing to try to complete this one. So if we see the head bobble or drop, we're going to go ahead and consider that dysfunctional. And then the last one's going to be that arms deep down squat. So we're essentially just looking at the entire weight of the person squatting, right? So we'll have them put their feet together, and I can't perform this one. I'm 100% dysfunctional, but we'll just have them descend into a squat, bringing their arms out. If they're able to clear that parallel area, which I'm not able to, so if they're able to get and clear that parallel area, then we're going to have them make 2 fists and bring it down to their side and touch the ground, and then ascend back up. A few things we're looking for: we want to simultaneously see the flexion of the hips with the knees, and we also want to see some dorsiflexion of that ankle, as well as just keeping that lower extremity in the sagittal plane. No toe flaring, no knees bobbling, anything like that. So yeah, thank you. And if I need to redo this with a subject, just let me know.